my name is Lisa Chan, and today I will be talking about the E in EFAST. Specifically, I'll be covering the evaluation for pneumothorax using point-of-care lung ultrasound. Several studies have shown that ultrasound has greater sensitivity than chest X-ray for detecting pneumothorax in supine patients. For example, a meta-analysis conducted in 2020 found that lung ultrasound had a sensitivity of 91% as compared to chest X-ray with a lower sensitivity of 44%. With that being said, let's use ultrasound for pneumothorax. First, let's talk about the setup. Ideally, you would use the linear probe for better resolution. However, you could also use the curvilinear or the phased array probes as part of your FAST exam. The patient should be in a supine position. Hypothetically, air should accumulate anteriorly as it is the least dependent position in a supine patient. However, studies have been performed in attempts to identify the optimal probe position without a clear winner. One retrospective study performed in 2011 suggests that an anterior-inferior position at the 5th to 8th intercostal spaces may be a more sensitive location. However, another prospective study in 2016 found that a single view at the 3rd intercostal space had comparable sensitivity and specificity to a 4-view protocol that examined more inferior and lateral positions. So, with all that being said, let's place our probe on the anterior chest wall at the 2nd to 4th intercostal spaces at the mid-clavicular line, as that is the most common starting position. Your probe should be in a sagittal orientation with the indicator pointing cephalad. Operators should identify the pleural line located between 2 rib spaces, also known as the bat wing sign. You will want to look for lung sliding, which is the movement of the hyperechoic pleural line between the 2 rib shadows. Note that in the image on the left, you're able to visualize clear lung sliding. Compare that to the image on the right, where the hyperechoic pleural line is at a standstill, meaning lung sliding is absent. Absent lung sliding has a 95% sensitivity and 100% negative predictive value, which in the appropriate context would be concerning for pneumothorax, although there may be other conditions that cause false positives. What are some causes of absent lung sliding not due to a pneumothorax? Some false positives stem from changes to the pleura that may decrease normal lung sliding, such as fibrosis, chronic adhesions, or a history of pleurodesis. Consolidations and effusions can separate visceral and parietal pleura and cause absent lung sliding. Lack of movement due to phrenic nerve paralysis, apnea, or atelectasis from right mainstem or esophageal intubation may also cause absent lung sliding. Another false positive is subcutaneous emphysema, which may obscure lung sliding as it obscures visualization of the parietal pleura. A partial pneumonectomy may also cause absent lung sliding, as there is no lung in the area that you are scanning. Other than looking for lung sliding, there are other findings on ultrasound that may help you identify or rule out a pneumothorax. You can look for B-lines or comet tails. You can use M-mode to visualize the seashore or the barcode signs. You can scan for the lung point or identify a lung pulse. You can also use power slide or power Doppler to identify subtle lung sliding. There are also false negatives. A focal or loculated or small pneumothorax can be missed if you're not scanning in that area. Cardiac motion or movement of your probe can, in some ways, mimic the appearance of lung sliding, therefore masking a pneumothorax. Comet tails or B-lines, which are a type of comet tail artifact, are hyperechoic lines that extend from the pleural line and move with lung sliding. This artifact is due to apposition of the parietal and visceral pleura, and therefore will not be seen when there is a pneumothorax. These hyperechoic lines are comet tails. Using M-mode, you can further visualize lung sliding. The image on the left represents the seashore sign, which represents normal lung. Compare that to the image on the right, which shows the barcode or stratosphere sign, which represents a pneumothorax. Lung sliding generates a sandy appearance below the pleural line. The absence of lung sliding generates a barcode image with parallel lines both above and below the pleural line. Lung point is pathognomonic with a reported 100% specificity for a pneumothorax. In patients with a pneumothorax, you will see an area without lung sliding adjacent to an area with lung sliding, which intermittently appears with respirations. During inspiration, sliding of the normal lung contacts the parietal pleura in an area containing collapsed lung. This can also be used to estimate the size of a pneumothorax. A posterior or lateral lung point would indicate a larger pneumothorax. This is the area with collapsed lung, and this is the area that has intermittent lung sliding that appears with respirations. Another helpful finding is the lung pulse, which is seen with absent lung sliding not due to a pneumothorax. It is caused by cardiac vibrations that are transmitted to the pleural surface, generating rhythmic movement at the pleural line. In order for these cardiac pulsations to be transmitted, the visceral and parietal pleura must be in contact with one another. Lung pulse is helpful in identifying false positive causes of absent lung sliding, for example, adhesions or atelectasis. In a normal lung, lung sliding predominates and obscures the lung pulse. You can use color Doppler to visualize lung sliding. In the image on the left, you can see that there is a lot of color at the pleural line. This indicates that there is movement at the pleural line and therefore no pneumothorax. In the image on the right, there is no color using color Doppler, which is concerning for pneumothorax. Power Doppler is a subtype of color Doppler and is more sensitive to lower flow than color Doppler. If you obtain the image on the right, you could then use power Doppler to increase your sensitivity for subtle sliding. Power sliding refers to using power Doppler to identify subtle lung sliding when direct visualization is suboptimal. If lung sliding is present, power Doppler will show color flow at the pleural line. However, to utilize power Doppler, operators must maintain a steady hand and discourage patient movement in order to prevent false color flow in a patient who truly lacks lung sliding.